This is a review of Chapter 9, the urinary system, and I get really excited about this because the urinary system and how it functions with our body is just pretty darn amazing. So when we look at the combining forms with the urinary system, we have two combining forms for kidneys, two combining forms for urine. It's really important that you know both of those because depending on the medical term will be dependent on which one is used. Okay, so when we look at that, the kidneys, the renal pelvis, urine, ureters, the bladder, the urethra, and we do look at the prostate because it actually can affect the urinary system. It's usually in the male reproductive system, but we also talk about it in the urinary system. So the function of the urinary system is actually to maintain homeostasis. And it does that by being able to balance the amount of water and salts and acids, because it actually filters the blood and it tells us, our body tells us what we need to hang on to and what we need to get rid of. So if we have too much salt, it's going to let us drop the salt. If our body needs salt, it's going to hold on to that and then be reabsorbed and pushed through the blood and the body. It also filters out waste products like urea, creatinine, uric acid, and then those waste products that they pull out and any excessive fluids that are there, it forms urine, and then we excrete them out of the body through the urethra. So when we talk about the organs in the urinary system, we're going to see two kidneys, two ureters, one bladder, and one urethra. When we look at the ureters and urethra, people get these mixed up all the time. So you're going to see here are our kidneys. They sit up higher than a lot of people think. We then have the ureters, one from each kidney going down into the bladder. The bladder is the holding vessel for the urine, and then it is excreted out of the body through the urethra. The kidneys sit in the retroperitoneal area of the body. And remember, peritoneum is the lining of the abdomen. They, again, filter that blood to remove waste products and excess water, help with maintaining the fluid level. It actually is very important in the production of hormones that help control blood pressure. And this is really important because when we have people who have kidney disease, we will see them have difficulty with blood pressure. Erythrocyte production, and also the activation of vitamin D. The renal cortex is the outer part of the region. It contains the nephrons. And the renal medulla, it actually is the inner region, and it actually contains the urine collecting tubules. So this is where I get excited because when we look at how urine is produced, it uses three different things. It uses filtration, it's reabsorption, and then secretion. So what if you look on your books on page 271, or if you're using your ebook, you can go to figure 9.2. It shows how the renal tubule and the glomeruli, Bowman's capsule works. And so when we look at that, the urine comes in. I did not mean urine. The blood comes in the body and it enters through our renal artery and it goes to the nephrons. From there, it actually starts the process of filtration in the glomerulus. And what happens is the blood is filtered because, remember, it contains the proteins, blood cells, and they're too big to get through to filter out of that filtration system. So they stay in the blood. The other things are pulled out. And then what happens, it goes into that filtrate goes into the renal tubule. And that's where the magic takes place. Because what happens is that communication that I talked about, the water, do we need sugar? Do we need salts? What do we need? If our body needs those things, they are reabsorbed into the body, again, the blood, through that renal tubule, and then the waste products are then carried on down through the urethra or ureters and into the bladder. So it really is quite amazing that our body can maintain that balance with simply looking at this, that Bowman's capsule and the glomeruli and the renal tubules and all of those things. Really is quite amazing to me. I don't have much of a life, okay? So the renal pelvis is actually a small area surrounded by the renal cortex and the renal medulla. And that's where the urine collection starts. So it'll all come through, all those waste products are going to come through. It's going to start collecting in the renal pelvis, and then it's going to start going to the ureters. Now, what we have to remember is those ureters are actually muscular tubes, and they have, just like the digestive system has, something called peristalsis. And that peristalsis is a wave-like motion, involuntary. We don't know that this is happening. And it actually helps carry the urine from the kidney to the bladder. And so that process of peristalsis helps that urine to be transported. There are 2 urethral orifices, one from each ureter, that allow the urine to drain into the bladder. The bladder, again, it's just a muscular reservoir for urine. It actually is lined with rugae, much like the stomach. So it allows for expansion when it's full, and then contraction when it's empty, just like our stomach does. The urethra is the tube that extends from the bladder to the exterior of the body. There are sphincters on each end of the urethra. Okay, that's what helps hold the urine into the bladder before we can expel it. The urethral meatus is, anytime you have a meatus, it's an opening to the outside of the body, and a urethral meatus is the opening of the urethra to the outside of the body. The female urethra is only about 1.5 inches long. It's located between the clitoris and the vaginal opening, and in females, it only transports urine. In males, it's about 8 inches long. The meatus is located at the tip of the penis. The urethra is twofold. It not only transports urine, but it also is part of the male reproductive system, because it also transports semen. The male urethra at the top is surrounded by the prostate gland, and this can cause problems in older men. Now, this is why we get, females get have many more urinary tract infections, because when we look, this is why your mom always told you to wipe from front to back, because if we don't, we can bring bacteria from the colon and put it near the opening of the urethra in women, and it only has to travel 1.5 inches to start an urinary tract infection. It has to travel 8 inches in men. And again, the tip of the penis is not located as close to the rectum as it is in the female. So that's why we see a lot more female UTIs than we do in men. The excretion of urine is known as urination. You'll hear people call it voiding, and also micturition. In order for us to excrete the urine, you have to have a coordinated contraction of those bladder muscles, as well as a relaxation of the sphincters. So there is a lot of nervous system moving for us to urinate. Looking at the specialist, a nephrologist is someone who specializes in disorders of the kidneys. A urologist actually is a specialist in diagnosing treatment disorders of the urinary system, but also in females, but it also does that and the male reproductive system for men. So a urologist, women can go to urologists specifically for the urinary system, but men go to urologists both for the urinary system and the male reproductive system. Some of the pathology that you're going to see in the urinary system, nephropathy is any disease of the kidney, and you'll hear that they have nephropathy. Renal failure, it is the improper function of one or both of the kidneys. And the problem with renal failure is it's the destruction of the nephrons that are there. And when those nephrons are destroyed, then when we talk about the glomerulus and that filtration and reabsorption, all of those things are affected, and our body can't maintain homeostasis correctly when you're having renal failure. Some of the things that you're going to see when we see renal failure are azotemia, which is an elevated BUN, which, if you look at your abbreviations, is going to stands for blood urea nitrogen. And that's going to be a blood test that they're going to draw. And we're going to have an elevation of that, and it's going to let us know that there's an issue. The reason this happens is because there is a lack of blood flow to the kidneys. Uremia is a toxic condition that results from renal failure. The urea and the other wastes that are normally just filtered through the kidney are not able to be filtered, and they're retained in the blood, and that can cause major issues for our patients. Acute renal failure just means it's a sudden onset of it. It can be fatal. Renal failure is nothing to mess with. It can happen after a surgery. Our kidneys go a little crazy, and they'll shut down. It can be affected by the medications that are being taken, just a shock to the body, but it's usually reversible. They'll do a lot of different blood work. They'll put a catheter in. They're going to help diurese. They're really going to watch the creatinine levels in the blood and make sure that we get the kidneys back to normal function. There is chronic kidney disease. And what happens with a chronic kidney disease, it is just typically a progressive loss of renal function. This can be very life-threatening. Again, a lot of people who have chronic kidney disease end up going on dialysis, and either peritoneal dialysis or hemodialysis. So those two things pull out those toxins, and they're not in the blood. Once they get past that chronic kidney stage, it's called end-stage renal disease, or ESRD. This is the nasty last stage of chronic kidney function. And at this point, unless a patient can get a kidney transplant, dialysis can hold them until they get the kidney transplant, but it really is towards the end of that patient's lifespan. This is one of the things that you can actually be put on Medicare for, because it is so debilitating. Nephrotic, it just means pertaining to the kidneys. And this is a number of conditions when there's a lot of proteins that are lost through the urine. Right? Edema. Edema is an excessive fluid accumulation in body tissues. Usually starts in the lower legs, but it can really start anywhere. And it can be caused by a nephrotic syndrome or other kidney diseases. A lot of people who have high blood pressure have a tendency to have peripheral edema because it's hard for the blood flow to get rid of the as the blood goes through, the fluid is not being absorbed. So usually they have to step in and give some type of diuretic or some type of therapy that helps move that fluid out of the lower legs. Hyperproteinuria, again, this is going to be an excessive amount of protein in the urine. And hypoproteinemia is actually a low amount of protein in the blood. So again, if you don't know, just simply look at the medical term. Emia, remember, is a blood condition of low protein. Break those words apart, okay? Hydronephrosis is actually a dilation of one or both kidneys due to an obstruction resulting in getting rid of urine. Okay, so we'll see this, like if somebody has a kidney stone, you'll see that they may give you a diagnosis of hydronephrosis because that stone is actually backing up or obstructing the urine flow from the kidney down to the bladder. Nephritis is just an inflammation of the kidney. Glomerulonephritis is actually an inflammation of those glomeruli in that with the Bowman's capsule, and it causes erythrocytes and protein to leak out of the urine. This is a big problem. Normally, the walls of the blood vessels are not large enough to lose protein and red blood cells. But for some reason, when the patients get this glomerulonephritis, that allows those erythrocytes and proteins to leak into the urine, which causes major issues because now we're not going to have enough protein, and we're going to start to see a decrease in our H&H and the loss of red blood cells. Sorry, I kind of got ahead of myself there. Nephrotosis is actually something, a prolapse of the kidney into the pelvic area. So it's actually kind of like a dropping or dropping down of the kidney. Nephropiosis is actually a suppuration. And when we look at the term, not separation, suppuration, that means that there is pus or infection. So there is some type of disease condition of pus in the kidney. Again, pio is the combining form for pus. It's a disgusting word, by the way. Just a little hint, when you're documenting in a medical record, we use the term, we don't say pussy, we say purulent, because if somebody goes to read that back, it may not be pronounced pussy. So anytime we have a disease that has any type of fluid that it's pus containing, the term is purulent that we will be using for documentation. Polycystic kidney disease, this is extremely difficult to live with, and they actually have a really good picture of it on page 275 or figure 9.6 in your book. It is just a number of fluid-filled cysts that grow on the kidney, and the problem is it starts to affect the kidney function, and it throws the patient into kidney failure. We see a lot of kidney transplants for people that have polycystic kidney disease. Renal colic, again, this is acute pain in the kidney area caused by a kidney stone. I don't know if you've ever seen anybody in pain trying to pass a kidney stone, but from what I understand, and I'm knocking on wood, I've never had one, it is worse than childbirth. I have seen grown men bend metal bed rails because the pain is so that it's so painful for them. And we have to think about, we're going to talk about stones, but they have little barbs on them. So as they're being pushed down with that peristaltic movement, um, they're grabbing into that muscular layer of the ureter. And so it is painful. Not only is it painful when it moves, it's blocking that urine. And so they're uncomfortable with all that urine backing up in the kidney, as well as the movement of that stone. Wilms tumors we usually see in children, and they're just a malignant tumor of the kidneys. Speaking of stones, we also call them a calculus or calculi for plural. There are a number of reasons people can get stones. It can be a mineral deposit. I know that they can narrow it down, test it. I know when my husband had one, it was because it was too much caffeine in his diet. He had to cut back his caffeine. People who have well water, have abnormally high amounts of different mineral content, will see them have frequent kidney stones. And it's really kind of interesting when you look at that, that they can actually get down to actually determine what the cause of the stone is. Nephrolithiasis is actually the presence of a kidney stone. A nephrolith is a stone located in the kidney. Ureter, forget that one. No, ureterolith is in the ureter, and a cystolith is actually a stone in the bladder. So it can move from the kidney down through the ureters, and then land in the bladder. Usually by the time it gets to the bladder, you don't have that pain anymore, and you can actually pass it just through voiding. Again, you can see here, these are the nephroliths. Here's the one stuck in the ureter, and you can see it's large and it's got those little barbs on them, and it's trying to squeeze through the ureter, and that's where that pain comes from. Once it gets down here into the bladder, it's a cystolith, and at this point we are able to pass it through the urethra, usually without any difficulty. Hydroureter is actually a distension of the ureter with urine due to a blockage, and we see that when we have, a stone in the ureter. Oh, poo, hang on a second. Ureter ectasis is actually the distension or swelling of the ureter due to having a stone there, or maybe a congenital abnormality that's there. And then ureterorrhea is the discharge of blood from the ureter. Again, that can be caused by the passing of stones. Cystalgia is just pain in the bladder. Cystocele is a herniation of the bladder, usually through the vaginal wall. We see this quite frequently. And interstitial cystitis is a common chronic inflammation within the bladder walls. We also have terms that talk a little bit about the backward flow of urine. Again, that doesn't always happen because of the peristalsis, but when it does, it's going to be vesicuria, that reflux. So remember how we had GERD, that gastric reflux? This is going to be very similar, and it's going to want to flow backwards. We can also have a vesicovaginal fistula, and that is an opening between the bladder to the vagina, and that can actually cause urine from the bladder to go into the vagina. And that's a problem because now we have bacteria that's normal in the urinary system now going into the vaginal system, and the vaginal normal flora going into the bladder, and it can cause major issues and infections. Neurogenic bladder, this can be caused by a number of different things. Again, it has to do with nerves. And so this could be congenital. This could be somebody who dove into a pool and they broke their neck high up into the cervical vertebrae, and they don't have any control of the bladder. This can absolutely cause urinary incontinence and the inability to empty the bladder. The prostate is a very big problem for men as they get older. Benign prostatic hyperplasia, it's just an enlargement of the prostate gland. The prostate gland surrounds the urethra, and if the prostate starts to grow and get bigger, it actually compresses the urethra. And so what happens is men have difficulty urinating. They have a difficult time starting to urinate. They have a difficult time, depending on how long and how far it is compressed, can have a real difficulty with urination. And you will hear this a lot about in older men. Prostate cancer is one of the most common cancers in men. It may be asymptomatic. It may be found when they're doing a rectal exam on a man, or it may be aggressive and cause that prostate to grow. Generally, prostate cancer is a slow-growing cancer, so if they find it, they can go in and do a prostatectomy and remove it, and then they don't have any problems or minimal problems. So when we go into the urethra, different issues with that. We have the urethrasia, which is bleeding from the urethra. We have urethraria, which is just a discharge from the urethra. Again, we're going to see this if there's a urinary tract infection, or in men, we may see that if they have an STD. We also have urethrostenosis, again, which is a narrowing of the urethra, and that can be caused from injury or some type of scarring from infection. They can actually go in and use a tool to actually stretch it for them to be able to continue to void. Epispadias is actually a congenital abnormality of the urethral opening. In males, it is the urethral opening is on the upper surface of the penis. In a female, the urethral opening is in the region of the clitoris. In hypospadias, it is in a male, the urethral opening is on the ventral surface of the penis. And remember, ventral is back. And in females, the urethra actually opens into the vagina, which is a major issue. Cystitis is just an inflammation of the bladder. Polynephritis is an inflammation of the renal pelvis and the kidneys. And urethritis is an inflammation of the urethra. Anuria is the absence of urine. Diuresis is what we do for patients who have a lot of fluid buildup. It is an increased urine output. Okay, so you'll hear people say they're diuresing a patient. Dysuria is painful and difficult urination, and enuresis is an involuntary discharge of urine. When we have children who have nocturnal enuresis, it's when they can't hold their bladder through the night. So a lot of times kids, as they're younger, are potty trained through the day, but it is more difficult for them to be potty trained through the night. So it may take extra time for that to happen. Nocturia is actually excessive frequent urination during the night. Oliguria is scanty or small amounts of urine. Polyuria is excessive urination. Urinary hesitance. This is when it's difficult in starting the urine stream. So this is somebody who's sitting on the toilet or standing in front of a urinal, and they really have to think about peeing and being able to relax those muscles to be able to get the start of that urine stream. Urinary retention is actually the inability to completely empty the bladder. So these are people that go to the bathroom, but then in 30 minutes they have to go back, because what happens is their bladder's not emptying completely. And they can actually, in the office, do an ultrasound and check to see what's going on with that. Incontinence is the inability to control the excretion of urine and or feces. Urinary incontinence is when you are not be able to control urination or voiding. Overflow incontinence is when you have continuous leaking from the bladder. So there's probably an issue with the sphincters. Stress incontinence. Welcome to motherhood, if any of you are out there. It's the inability to control voiding under physical stress. So when you're sick and you're coughing and then you pee a little bit or you laugh, in pregnancy, this is very common too, because that baby's sitting on the bladder. So it's very, very, stress incontinence is very, very common. An overactive bladder just means that the bladder muscles are sending signals to our brain that, oh my gosh, you've got to pee, but the bladder's really not full. It's just sending those messages that you've got to go to the bathroom. Urinalysis is a diagnostic procedure we use to determine the presence of abnormal elements like protein, sugar, those type of things. And there's a number of different types of tests that can be run. A bladder ultrasound, again, we can see stones with that. We can see an enlarged prostate, and we can measure that residual urine for those people who can't expel all the urine from their bladder. Urinary catheterization is when we're inserting a tube into the bladder. It is a sterile procedure. We use sterile gloves and sterile process to get a urine sample. Now, there's different types of urinary catheterization, and they're going to be coming up shortly. But you can have an indwelling catheter, which they insert, they blow up a balloon, and it stays in place for a period of time, maybe after surgery, and then they pull it out. We can also do this straight cath, where people who aren't able to have that don't have the nerves to be able to urinate, they may have to cath themselves, do a straight cath every 4 hours to be able to void and get the urine out. Cystoscopy is actually going in for the process of doing a visual exam of the bladder. Avoiding cystourethropography, is when they're going to use fluoroscopy to determine the flow of urine from the bladder through the urethra. It's pretty cool to watch. A CT, computed tomography, we can use to evaluate the urinary system, and blood test, glomerular filtration rate, is actually to see how the kidneys are doing filtering the blood. A cystograph or cystography is going to be an x-ray of the bladder. We use a contrast media for this. So again, the cystography or cystogram will be the picture or record. The cystograph is going to be the instrument used, and cystography is going to be the process of doing the test. Okay, an IVP or an intravenous pyelogram is going to go in and again look at the kidneys and the ureters. Again, requires a contrast media. We've got to be really careful with this with patients that are diabetic, because this can cause a major issue with their creatinine levels. KUB, which is kidneys, ureter, and bladder. Again, it's a radiographic exam. They're going to look at detection of the bowel obstruction or the nephroliths. It does not need a contrast medium. And a retrograde urograph, again, observes the upward flow of urine. It does need that contrast media that we talked about. And there's the old digital rectal exam. This is when the doctor puts a glove on, lubricates that, and they put a finger up into the rectum to palpate the prostate gland. Not comfortable, but this is actually one of the best ways to be able to monitor the size of the prostate. You can do a prostate-specific antigen blood test, PSA. There's a lot of controversy with that right now. It does screen for prostate cancer, and usually men get that, but there's still a lot of controversy if it's useful or not. There's a number of different medications that we can use. Diuretics, again, going to help us get rid of those excess water, and salt. And we've got to be careful of that because that can actually put us in issues with not losing too much salt and too much potassium. So we need to be careful with those things. Antibiotics are going to treat UTIs, and antispasmodics can actually help people who have spasms of the urethra or the bladder or the ureters. It's very uncomfortable. There are nutritional interventions as well, monitoring our sodium, potassium, protein, phosphorus in our diet. If this is a real issue, you'll go to a nutritionist or a dietitian and work with them. Dialysis, we talked a little bit about. There's two different types of dialysis. When our body can no longer remove the waste products, we have to do something to help it along. We start with peritoneal dialysis, which there's a little opening that goes into the body. We drain, we put fluid in, we let it sit in there for a bit, we drain it, and it helps pull out those toxins. When the peritoneal dialysis is no longer working, they then go to hemodialysis. And then they have to go into a hemodialysis unit. It's usually outpatient, depending on how bad they are, is the amount of time that they're there. They put a shunt somewhere in the body. They hook it right to the machine, and the blood is taken out of the body. It is cleaned, and then it's put back in. So it's really quite interesting. Nephrolysis is, again, it is surgical freeing a kidney from an adhesion. Nephropexy is actually the surgical fixation of a floating kidney. Nephrostomy is actually placing a catheter to maintain an opening from the pelvis to one or both of the kidneys. So that would be an ostomy. Remember, ostomy is an opening to form a mouth. Okay. Pylotomy is actually a surgical incision into the renal pelvis, and a renal transplant is actually a kidney transplant. You know, they take that old kidney, they don't actually take it out, they just rehook the new kidney in, and then it starts to hopefully filter with that. Treatment for nephroliths, those stones, there's a couple different ways to do that. Extracorporeal corporeal shockwave lithotripsy. What this does, it actually breaks the stones up into little pieces, and then we're able to just excrete them in the urine. So we don't have to pass a big stone. It breaks that stone up, and then we pass them. If they can't do that, or if they think the stone is wedged, they can do a percutaneous nephrolithotomy, which is the surgical removal of that nephrolith. And they make a little opening in the back, they go in, and they get that out. Again, the ureterectomy is going to be a surgical removal of the ureter. Ureterorrhaphy is the surgical suturing, and ureteroscopy is going to be the process of going in and visualizing that. They can actually grab the stone if they can, and then they'll put a stent in for a short period of time, because the swelling sometimes will cause the blockage of urine as well. So they'll go grab the stone, they'll put the stent in, and then in maybe a week, they'll pull the stent out once that inflammation is gone. The cystectomy is, again, removing part of the urinary bladder or all of it. Um, Ileoconduit is a small piece of intestine to help the urine get to the ureters and then out to an abdominal stoma. And remember, ileal, I-L-E-A-L, the ileum is the second part of the small intestine. Cystopexy is a surgical fixation of the bladder. The lithotomy, again, is going in and removing that nephrolith from the bladder. We talked about the indwelling catheters already. So they remain there for a long period of time. Foley catheter is what you're going to hear. The urethral catheterization or straight cath is when somebody puts that in and then they take it out. And that's that intermittent catheter as well. Suprapubic catheterization, they actually put a catheter into the bladder from a small incision in the abdominal wall. And then they're able to drain the urine that way. Mediotomy is going to be an incision into the urethral meatus. Urethroplasty is a surgical repair of the urethra, and urethrotomy is going to be an incision into the urethra. Treatments of the prostate are an ablation. An ablation just means we remove part of the body or destroy it because it's not functioning right. So they may go in there and remove part of that. A prostatectomy is actually the removal of part or all of the prostate gland. Transurethral prostatectomy, actually they do that, and there is a lovely picture of that in your book. Guys, just hold tight. It's on page 286 or figure 9.18. They actually put a scope in and they pull out the little pieces of excess, they remove that excess tissue of the prostate gland. You can use radiation therapy, there's hormone therapy, there's all different, they can plant chemo seeds in so it helps decrease the cancers within there. There's just so many different treatments for prostate cancer. Because it's a slow growing progression, there are some times when we have older people in their 70s or 80s that they're not going to do anything for because this is so slow growing. They're going to die of old age before the cancer would really affect them. Things that we can do for urinary incontinence are Kegel exercises. Believe it or not, they work beautifully. Bladder retaining. You can actually, our physical therapy offices locally actually do a lot of this bladder retraining. It's a behavioral therapy, but it also it works the muscles, the core muscles of our body, but we also increase the time that we go to the bathroom to help build our muscles slowly. I think that's it for the chapter. If you have any questions, please reach out. Thanks.